Good afternoon again, everyone. This is Liz Purcell, and thank you for joining me for part 2 of the nutritional management of inflammatory bowel disease. During this lecture, we'll be looking at a specific case study and exploring the uses and benefits of exclusive enteral nutrition. So what are our specific goals in the nutritional management of patients with IBD? Ultimately, we want to provide a safe and effective treatment option for the management of inflammatory bowel disease. So what do we currently know? We know that diet is implicated in the pathogenesis of IBD. We know that malnutrition is at unacceptably high levels in IBD, and this directly affects the course and outcome of the disease. We know that diet has a plausible role in altering the gut microbiome and the innate immunity. And we know that the use of EEN has expanded from a tool for induction of remission in children at disease onset to a tool with potential to treat very complicated long-duration disease in adults. Perhaps the most exciting development is the potential to induce and maintain remission by use of exclusive diets or partial enteral nutrition, PEN, which would enable wider use of dietary therapy across the spectrum. Moving on to the case study then. This is a 45-year-old lady that I saw about a year ago in clinic. She had ileal Crohn's disease, which was diagnosed in 2000. She lives with her partner. She has 2 children, aged 27 and 19, and she herself works part-time in childcare. She is a non-smoker with minimum alcohol consumption. Her past medical history includes Crohn's disease, osteopenia, and depression, which is very common in chronic diseases, but particularly so in IBD. Her disease to date has been kept stable on 10 milligrams per kilogram of infliximab, which is a biologic that we discussed in the first lecture. And she was also on a calcium and vitamin D supplement. So for my initial consultation with IBD patients, I usually allow about 45 to 60 minutes to allow me to obtain a thorough assessment. Starting with things like anthro. So the predominant take-home message here is that she had approximately a 10% unintentional weight loss in 2 months. Her biochemistry, general Chem 20, full blood count, use and liver function tests were essentially unremarkable. However, her C-reactive protein, which is an inflammatory marker in her blood, was high at 27. This should be ideally below 5. Consequently, her albumin, which is an acute phase protein and responds to inflammatory markers, was low, as I would expect. Her calpro, which is a very, very sensitive marker of inflammation, albeit it's not a specific marker of inflammation, is found in the stool sample, and that came back as 440, which was very high. That should be below 100. To put that into perspective, I have a patient in hospital at the moment who has a calpro of 62,000. So again, it's very, very varied, but ideally it should be below 100. Clinically, her bowels opened 3 to 5 times a day, and they were loose in consistency, but no blood present. She described feeling lethargic and described some hair loss over the last couple of months. Again, we talked about the unintentional weight loss, and this was predominantly secondary to early satiety. Her preliminary MRI showed a 20 centimeter terminal ileum wall thickening with dilated loops of small bowel. This was unchanged from a previous MRI she had 6 months ago, but there was no evidence of fistula present. Dietary, as I mentioned in the first lecture, never set and forget. Make sure that you always monitor progress and adapt your dietary interventions accordingly. So you can see here I worked out her nutritional requirements using her actual body weight of 70 kilos, and I used 30 to 35 calories per kilogram per day, which is equivalent to 125 to 145 kilojoules. Similarly, from the protein point of view, she had good renal function. She was a relatively young woman, so I used 1.3 to 1.5 grams of protein per kilogram per day. So following numerous appointments that day, the decision was made by the gastroenterologist to admit our patient overnight for intravenous therapy, which would include analgesia secondary to her Crohn's disease flare. She was prescribed free fluids only, and I was asked to see her to discuss exclusive enteral nutrition, or EEN, with a view to inducing deep remission and aiming to avoid the need for corticosteroids. Initially, she was very, very reluctant. Obviously, with any patient that comes in, she was afraid, she was quite tearful, and the thought of not having any food for 6 weeks, as you can imagine, was a little bit confronting. However, she completed it. I saw her every week for the duration. She completed the 6 weeks on EEN. Following that, we did more bloods and another stool sample, and her calprotectin, which is the very sensitive marker of inflammation, came back at 130. So previously, or pre-EEN, it was 440. So a significant reduction, which was fantastic. Clinically, she was feeling well, and she reported feeling great. Following her 6 weeks on EEN, the consultant repeated her MRI and took numerous biopsies, which now showed only minor active inflammation at her anastomosis point, and the inflammation was now measuring less than 5 centimeters, which was a reduction of over 5 centimeters. The biopsies taken from her right transverse descending and sigmoid colon were all within normal limits, which showed a significant improvement, and the conclusion of the MRI was that no dilatation was required at this stage. As you can imagine, she was delighted, and her summary of the EEN was that it was totally worth it. The reason I chose a case study using EEN is that I have a particular interest in the role of EEN in the management of patients with Crohn's disease, for the simple reason that it is the only treatment option available to patients which carries no risk and minimal side effects. EEN is a very well established, very well researched first-line treatment in babies and children with Crohn's disease with an approximate 80% success rate. Historically, though, diet had always been disregarded as having a role in driving or treating inflammation in this cohort, but this impression has changed quite dramatically since the proven efficacy of EEN. At the moment, the data supporting its use in Crohn's disease probably isn't robust enough for this to be considered a routine first-line treatment in adults, despite there being similar efficacy to that of children, coupled with its potential to reduce the need for high-risk steroids. Practically, issues like tolerance, lack of experienced dietitians, and overall lack of support are reported as the main reasons for much less success in adults. That said, the use of EEN in adults in countries like Japan is certainly regaining momentum both in the literature and clinical practice, again particularly relating to its lack of side effects. Therefore, EEN should be considered in acute Crohn's disease patients as a treatment option, particularly for those who are at high risk from alternative therapies like steroids. And they would be predominantly the very old, the very young, and pregnant women. EEN was advocated as a first-line treatment in the early 1990s. Contemporary consensus guidance from major organisations like ECHO, which is the European Crohn's Colitis Association, and ESPEN, the European Society of Parenteral and Enteral Nutrition, amongst others, directed clinicians to use EEN to induce remission wherever possible. These guidelines helped to reinforce the position that steroids or early immunosuppressive therapy should always be reserved for patients where EEN was not an option. The exact mechanism remains unclear, but several options have been proposed, and these include an improved mucosal permeability, improved immune function, altered gut flora, and a reduction in the inflammatory mediator response. In fact, the speed at which EEN seems to reduce inflammatory markers, which is 2 weeks initially, suggests it has a global anti-inflammatory effect. In addition to all of this, EEN has been shown to promote weight gain in underweight or malnourished patients. It has been shown to improve vitamin D status, enhance bone turnover, and generally improve the quality of life of patients during and after treatment. So what exactly is EEN? Essentially, it's a liquid polymeric diet which can be taken orally or given via an NG tube for roughly 6 to 8 weeks. At the moment, there's no controlled trials looking at the appropriate length of treatment. Therefore, current practice is based on consensus or expert opinion. You may have noticed in one of my earlier slides, I had a picture of an elemental formula. That's because 100 years ago, when I went to university, this was the formula of choice, simply because it was a pre-digested feed which allowed complete gut rest while providing 100% nutrition. However, since then, numerous studies over the years have shown no difference between using elemental and polymeric formulas, and we know that polymeric formula or a whole protein formula are significantly better tolerated. As I mentioned earlier, we now know that EEN carries similar efficacy in both adults and children, but there is significantly poorer adherence in adults, and that's essentially the backbone of my research into the use of EEN. We know that when it's tolerated, it has the potential to be as effective as steroids in inducing remission. So when is it clinically indicated to use EEN? Well, there are a number of occasions when we know it can be particularly beneficial. For example, inducing a remission of Crohn's flare, managing Crohn's complications like a fistula or stricturing disease. But also it has many noteworthy uses when it comes to the surgical management of patients with Crohn's. And this is illustrated very nicely in a paper by Harashing et al. Published in 2017. I've included the reference below, and we'll look at that paper in a little bit more detail in the next couple of slides. It's important to note that despite significant improvements in health and healthcare over the years, approximately 70% of patients with Crohn's will develop stricturing or penetrating complications which require surgery. And this is known to occur within the first 20 years post-diagnosis. Surgery, though, is generally undertaken when all other options have been exhausted, and arguably when patients are at the highest risk of post-op complications. So this is the paper that I alluded to a couple of moments ago. In this particular paper, 51 patients who were treated with EEN prior to planned surgery for stricturing or penetrating complications of Crohn's were identified. Of these, 38 patients had surgery, and they were each matched with 2 control patients for disease behavior, type of surgery, age at diagnosis, and disease duration. Data and disease phenotype, nutritional status, operative course, and post-op complications were also obtained. Of these, clinical status improved in 25% of the patients, so much so that they no longer required surgery. EEN was shown to have no effect on pre-op weight, but it significantly reduced serum CRP levels, which are the inflammatory markers in the blood. It reduced length of surgery in patients who were pre-optimized with EEN, and most shockingly, the authors confirmed that patients going straight to surgery compared to those pre-optimized with EEN were associated with a 9-fold increase in the incidence of post-op complications. So the study concluded that EEN in adult patients presenting with complications is associated with a reduction in systemic inflammation, post-op times, and the incidence of post-op abscesses or anastomotic leaks. So while these results are extremely promising, the numbers in this study are small, and further control trials are needed to elicit how EEN may improve operative outcomes, and to confirm that EEN does in fact provide a safe and effective bridge to surgery. This study by Ashton et al., published in 2018, gives a nice illustration of the mechanisms of EEN and is well worth a look. This slide simply summarises a number of studies which highlight the particularly high remission rates that can be achieved using EEN. A number of these studies also show additional benefits which you may be interested in looking at a little bit further. For example, EEN's ability to induce mucosal healing and the fact that it's deemed superior to steroids in some cases for inducing remission. Duration of EEN regimes should be determined by the purpose and the clinical goal of using EEN as a treatment in the first place. To date, there have been no published control trials comparing length of treatment on EEN, and there is huge variation in the duration of EEN used in the literature, ranging from as little as a week to 10 days to more than 3 months. So current practice is based predominantly on expert opinion. The recommended duration for EEN should be determined, as I said, by your clinical goal and is summarised nicely in the table below, which I've taken from our OSPEN EEN clinical practice toolkit, which I will be referring to a little bit later on. In addition to the mechanisms of actions, it's important to spend some time discussing some practicalities associated with taking EEN with your patient. So for example, how to improve palatability, little tips and tricks of the trade to enhance their compliance. And these can be simple measures like taking them cold, having them through a straw, being aware that they can freeze the drink so they come out like a frozen yogurt or ice cream consistency, or in terms of the fruit juice versions, they come out like an ice block. In addition, flavours such as the chocolate and the coffee ones can be heated and taken like a hot chocolate or a milky coffee. Just remember not to boil them. Acknowledging that consuming the volume required in some cases can be an issue, and discussing ways of assisting that, for example, aiming to have 1 drink every 2 hours rather than focusing on the routine of breakfast, lunch and dinner, can help quite considerably. Another potential issue is to be aware of the possibility of having green stools. Now, incidences like these are much less confronting for a patient if they're aware it may happen and are reassured that it's completely normal. That said, the incidence of green stools were much more apparent when we were using elemental formulas, as its hyperosmolar concentration significantly increased transit time, and the green colour was simply bile being carried through in the stool. In addition, some patients may describe feeling quite tired or lethargic, but this appears to be particularly in the first week, and in my experience tends to dissipate after that time. Additionally, at risk of appearing sexist, one recurring theme when I start men on EEN is the fear of feeling hungry, but they soon see that the formulas are in fact very rich and are adequately filling. One final thing that I didn't add to this list is the potential for an aftertaste or sometimes bad breath on EEN. Therefore, I encourage patients to brush their teeth regularly, or in extreme circumstances, I will allow a sugar-free gum. I encourage them to only chew the gum for about a minute or 2 after each EEN carton is taken, rather than chewing on it excessively throughout the day, which may lead to bloating and wind or general abdominal discomfort. While EEN clearly has its limitations in that it is undoubtedly a tough diet to follow, and it's arguably much easier to pop a steroid tablet or pill, its positives cannot be underestimated. The most striking positive being the safety aspect and its lack of side effects, in addition to all of the other pros outlined here. Personally, I'm a big fan of Simon Sinek's work. He has written a lot of books and produced a lot of podcasts on leadership. And one of the things he always says is people people don't buy what you're selling, they buy why you sell it. And I believe this to be very true in this instance. I see it very much as my role to promote the value and to highlight the benefits of EEN. Of course, you're not always going to convince everyone, but you are there to provide the patient with accurate and up-to-date advice, offering understanding and empathy and support so that they have enough information to make an informed decision of their own. When you get to the stage of food reintroduction with your patient, the goals are essentially the same whether the patient has been on EEN for 6 weeks, 8 weeks, 12 weeks. So ultimately, you're looking to reintroduce foods gradually to avoid exacerbation of symptoms, to modify the fibre or lactose content of the diet if clinically necessary. And remember, we discussed that in lecture 1. I don't tend to restrict fibre unless there is stricturing disease present. Ultimately, you're looking to obtain a balanced diet with a variety of foods, and that should include, where possible, fibre, lactose, gluten, etc. To be aware that food intolerances may be present, which may induce relapse, and to identify those who would benefit from a total exclusion diet. This graph here gives you one possible scenario on food reintroduction, and I've taken this particular example again from our Aspen Clinical Practice Toolkit. But essentially, a non-restricted diet can be reintroduced quite quickly after a prescribed course of EEN, which ideally the patient has been on for 6 to 8 weeks. But again, that depends on your goal of treatment. My usual procedure in this scenario is to reduce the EEN to approximately 50%, so that it is still providing partial EEN, or PEN for short, while allowing the patient to introduce possibly 2 or 3 small snack-type meals a day initially. The EEN formula is then further reduced and the meal frequency increased over the next week to 10 days, but this is very much dependent on the tailored approach and agreement between yourself and the patient. Remember that the regime can also be personalized by yourself with consideration for components such as the presence of stricturing disease, of course the patient's preference, any comorbidities they may have, how motivated the patient is, and absolutely considering their quality of life. I want to draw your attention to this document, which is a practice toolkit specifically designed for dietitians and is available to all members on the Aspen website. I was one of a working group of 12 multidisciplinary IBD specialists across Australia and New Zealand who were convened by Aspen to develop a practical, clinically focused care pathway for the use of EEN in adults with active Crohn's disease. The aim of the work was essentially to develop this pathway, which would help standardise care across the country and could be used to benchmark practice and essentially provide direction for further research down the track. We identified 6 key areas, which included clinical indications, nutrition assessment, the EEN protocol itself, monitoring, accessing formula, and finally food reintroduction. We carried out a systematic review and quality evidence was graded. Where there was no evidence, consensus expert opinion was used. The consensus statements which we developed are easy to implement, practical, and were based on best available evidence or expert opinion at that time. This is just a snapshot summary of the optimal care pathway itself. Regarding monitoring your patient while on EEN, the standards principles apply as outlined here and as I previously discussed in lecture 1. But monitoring should be done regularly by all members of the multidisciplinary team in order to encourage and support the patient's adherence to EEN therapy. The IBD team usually includes the consultant, an IBD specialist nurse, the dietitian, and where possible, a psychologist. Personally, and for the purposes of my research, I monitor all my patients on EEN a minimum of once a week, and that's done via a face-to-face consultation or over the phone, whichever is easiest for the patient. But they are also given open access to me and encouraged to phone with any queries. It's important to note that if EEN therapy does not result in the patient's symptoms improving, and consequently the patient feeling better as a result, an alternative therapy should be considered after the initial 2 weeks on EEN. And finally, I want to touch on dietary interventions during a remission. It's important that this is not overcomplicated. Keep it simple. I strongly advocate for a normal, healthy diet, which is low in processed foods and emulsifying agents where possible. Avoiding fad diets, particularly those which excessively restrict core nutrients or essential micronutrients. I've included here that this may be a good time to investigate any IBS type symptoms. It's important to note that patients with IBD are 3 times more likely to experience IBS type symptoms. But diets as restrictive as low FODMAP diets and the like are never warranted when a patient is in a flare. So it's important that that's assessed accurately. So to reiterate, go back to basics, keep it simple, encouraging moderate protein, complex carbohydrates, fiber as tolerated, low fat with an emphasis on avoiding highly processed and highly emulsified foods, and finally monitoring the diet closely for possible micronutrient deficiencies and supplementing as required. In conclusion, inflammatory bowel disease prevalence is increasing. Nutrition therapy in IBD is an evolving area, so treat to target rather than just symptom control. EEN can induce clinical remission and/or can prolong remission as an adjunct therapy. There are other emerging diets which are showing good potential but are pending more research prior to us being able to use in clinical practice. And finally, remember that the EEN Optimal Care Pathway and manuscript are available to guide your use. I've included the ESPEN guidelines as a point of reference for you and an absolute essential to add to your file in relation to IBD. Thank you all very much for your attention, and I wish you all the very best of luck in your studies and your future careers as dietitians. If you have any questions, I'm more than happy for you to contact me. My email address is liz.purcell@health.qld.gov.au. Thank you all. Bye-bye.